Good morning, dear students. Today we will discuss about gestational age assessment. As we have discussed in the last lecture about the differentiation between term and preterm, that was also a part of gestational age assessment. And today we will further discuss about the precise gestational age assessment, the various scoring methods for the precise gestational age assessment will be discussed today. First of all, the in the gestational assessment, what are its types and need. In type, we can say that gestational age assessment, depending upon its time of doing this gestational age assessment, we can divide gestational age assessment into basic two categories. One is antenatal assessment, and another one is postnatal assessment. Antenatal assessment, when we do the gestational age assessment before birth, that is in utero assessment of the fetus for its gestational age. And its requirement basically is when the mother is not knowing last menstrual period, date of the last menstrual period, because most of the time we assess the gestational age of a fetus by LMP, and if mother is not knowing or not remembering the LMP, then it is very important for assessing the gestational age on various other parameters for assessment of the growth of the fetus, and to rule out any discrepancy between fetal size and its gestational age. Maybe that on the basis of fundal height we are assessing the gestational age of a fetus to be 24 weeks, but LMP is indicating that it is 28 weeks. Then there is discrepancy, and this discrepancy may be ruled out by other measures, so that it may be a case of IUGR, intrauterine growth retardation. The fetus would have been of 28 weeks, but as such growth is not proper, then it looks like 24 weeks on the basis of its growth, that is fundal height maybe. This discrepancy may be ruled out by gestational age assessment. And another thing in this particular example may be that mother may have missed the date of last menstrual period. She may be considering it maybe 20th Feb, but it may be 30th or this 20th March. Then there is a gap of 4 weeks, and that's why the fetus is looking like 4 weeks smaller than assessed by LMP. So these may be the conditions where there is need of gestational age assessment. Another need of gestational age assessment in utero, that is most important, is when we want to induce labor due to any condition. It may be some fetal conditions which may not be permitting the baby's growth in utero, or it may be a mother's condition. Mother may be suffering with some acute serious illnesses which may result in a fetal loss or fetal growth retardation, or maybe some fetal injuries wherein we want to induce labor and deliver the fetus. But before delivering, we have to assess that is fetus viable outside or not, and this viability will be assessed by the maturity of fetus, and maturity is dependent on the gestational age of the fetus, and that's why gestational age assessment is done in these cases where we induce labor. This is all about antenatal assessment. And then in postnatal assessment, which usually we do in labor room or on the first day, that is after birth we do the gestational age assessment of newborn. And its requirement is basically for grouping the babies into basic 9 groups, as we have discussed earlier in the class, that newborns may be grouped into one of the 9 categories, like preterm, small for date, preterm, appropriate for date, preterm, large for date. 3 groups of preterm, likewise 3 groups of term, and likewise 3 groups of postterm. We can divide a newborn into one of the basic 9 categories, and This can only be done on the basis of birth weight and gestational age assessment, and that's why gestational age assessment is required at that juncture for grouping, and on the basis of this grouping we assign the level of care for the newborn, that this particular newborn will be nursed alongside mother, or maybe nursed in nursery, or may require an ICU care. This particular assigning the level of care is also done on the basis of grouping of the babies. That is basic need of the postnatal assessment of gestational age. Now we will discuss one by one the methods how we assess antenatal gestational age and postnatal gestational age. The antenatal age gestational age assessment, we will not I will not go into deep into the its methods, but a few of the clinical methods are last menstrual period, usual and most frequently used tool for the assessment of gestational age in utero is the date of last menstrual period. From here we will calculate the today's gestational age, but it will always overestimate the gestational age by 2 weeks. Then another method, clinical method for gestational age assessment for antenatal period is height of fundus. If fundal height up to 12 weeks, we know that it is in pelvis, the fundus or uterus, fundus of the uterus is in pelvis, then it will come out at the rim of the pelvis, and then 16 weeks and 20 weeks, 24 weeks, we know the height at this level, it will be on this particular gestational age, but it is not a definitive method because there may be discrepancy between the growth and the fundal height. Then some other methods are appearance of fetal heart sound, and usually fetal heart sound appears 16 to 18 weeks of the gestation, but it is not a definitive method. Also quickening, we all know that the feeling of movements by mother, fetal movements when perceived by mother is known as quickening, and it is also a subjective finding. Usually quickening occurs in primi by 18 weeks, and in multi it may be as early as 16 weeks, but it is also not a definitive method for assessing gestational age. The other clinical method is USG. The ultrasonography is most accurate and most commonly used after last menstrual period. It is the most commonly used method for gestational age assessment, and herein we usually measure femur length and fetal wide measurements. Usually if you see the USG report of a pregnant lady, then there will be given some measurements that head circumference or BPT, biparietal diameter, or abdominal circumference, femur length, or ovoid, that CHL, crown hill length, or ovoid measurement, that on the basis of these measurements there are softwares which will calculate the gestational age of the fetus, and this is one of the most accurate method for the assessment of gestational age of a fetus. These all were clinical methods, and there are other methods of gestational age assessment in utero, and in them one is biochemical method. In biochemical method usually we assess various levels of amniotic fluid. Basically urea and creatinine will increase with the maturity of gestational age, and a creatinine level of more than 2 milligram per deciliter indicates that the maturity of the fetus is 36 weeks or more. And another biochemical method wherein we measure lecithin, sphingomyelin. These two chemicals are being measured in amniotic fluid. We aspirate amniotic fluid and we measure lecithin sphingomyelin ratio, and if this ratio is more than 2, that sphingomyelin is half of the lecithin, then it indicates a satisfactory lung maturity. We can induce labor if this ratio is more than 2. But one exception in this particular less than sphingomyelin ratio is if mother is diabetic and this ratio comes out to be more than 2, still we can't say that fetal lung are mature enough. There may be a wrong interpretation of this ratio when mother is diabetic. The exception should always be remembered. Other methods are also there for antenatal assessment of gestational age. I have not included them in this slide. And the other two methods are, one is cytological method. Usually we also not do these methods. In cytological method, one is mother's vaginal wall cytology, wherein we see that there is superficial increase in superficial cells as term approaches. And another cytological method is the cytology of amniotic fluid, and here we see squamous cells, and these squamous cells increase after 30 or 32 weeks, and after 37-38 weeks they are most abundant in amniotic fluid. And if we have aspirated amniotic fluid, we can go for amniotic fluid cytology, which will give us the idea about maturity of the fetus. Another one method for antenatal assessment, apart clinical, biochemical, and this cytological, is radiological method. But usually we do not follow radiological method because it give exposure of X-ray. And in radiological method we can go for X-ray, and in X-ray we look for epiphysis, ossification of the epiphysis of lower limb. Usually lower end of femur ossifies, or the epiphysis appear by the age of 36 weeks, and the upper end of the this tibia appears by 38 weeks. But they are not absolute, because in some conditions like in intrauterine growth retardation or in cretinism, the ossification may be delayed, and mere absence of these ossification centers may not indicate that fetus is not mature enough. So, however, this particular method is not in practice. The practical methods are either clinical or biochemical. Then we will discuss about postnatal assessment, and this is most important topic for today's discussion. In postnatal assessment, as we have discussed in last lecture, that we either precisely uh, go for the gestational age assessment, basically in preterms, and either we go for term and preterm differentiation. Term and preterm differentiation is done basically on physical findings, while precise estimation of gestational age is both based on physical as well as neurological examination. In physical examination, basic 5 physical characteristics we have discussed in last class, that includes plantar surface, that is plantar ridges, genitalia, breast nodule, ear cartilage, and hair. Apart from these 5 basic physical characteristics, there are two more physical characteristics which are graded or scored in that Vallard scoring method, wherein we assess or we calculate gestational age by the score attained by the newborn. In that particular Vallard score, there is two more physical findings which are scored. In them, physical findings, there is skin texture, and usually skin texture, in skin texture we inspect skin, and even we pinch the skin for its consistency as well as its thickness, and we score it. Usually in preterms we found that skin is thin as well as gelatinous. As term approaches, skin becomes more and more thicker and smooth, and term and after term it starts peeling off the skin of the hand, and these palms and soles, there is peeling of the skin as well as cracking of the skin. In post terms we usually say desquamation of the hands, these palms and plantar surfaces. So on the basis of these findings, we score the skin in Ballard scoring. Then another physical finding is Lanugo. Lanugo increases after 26 weeks, and after 34 weeks it starts disappearing. And staging of Lanugo, we can score that. Initial we give score when Lanugo arrives, and then appearance of Lanugo, then abundance of Lanugo, then walled patches of the Lanugo, and then absence of the Lanugo. This is how we score Lanugo. Lanugo, you all know that Lanugo is body hairs. And then after these physical findings, there are some neurological examination that is most important in this class. In neurological or neuromuscular examination, basic four headings we will discuss, and these include muscle tone, joint mobility, automatic reflexes, and fundus. We will discuss one by one them. This is Ballard score. Here you can see that in first table there is neuromuscular maturity, and neuromuscular maturity is assessed by it is not very clear, but you can read even score minus 1, 0, 1, 2, 3, 4 and 5. And here below score you can read that there is posture, scoring of the posture. Various postures are made. In next slides we will discuss all these things. Then there is this square window test, and then arm recoil, popliteal angle, scarf sign, and the last one is heel to ear test. These all are neuromuscular tests which are being scored in Ballard score. Then some physical maturity is also scored in it. You can see that there is skin, Lanugo, plantar creases, breast nodule, eye and ear, genitalia male, genitalia female. Here is not there. Then we will discuss them one by one. First of all, muscle tone. What is muscle tone? Muscle tone, usually when we are not doing any work, still there is some contraction of some muscle fibers, and this partial and continuous passive contraction of some muscle fiber will give some tension in the muscle. This residual muscle tension is known as muscle tone, and it usually is being assessed by passive stretching of that particular muscle. Like if we want to know the tone of the biceps muscle, the work of biceps is flexion of the elbow joint, and if we do extension of the elbow joint and there is increased tone of the biceps muscle, there will be a resistance we will feel during the extension of the biceps muscle. Like when we go to gym and do some biceps exercises, biceps becomes tough, there is increased tone, and there will be stiffness in biceps when we try to extend the elbow. And this particular resistance felt during passive movement is tone, and this particular tone is required to maintain some postures. Usually when we are sitting or we are standing, there are some muscles which are in contractions, and this contraction will give us a particular posture. Then due to this continuous and passive partial contraction, so this muscle tone usually we assess by three basic measures. One is by posture, how the posture is being maintained. Then second, we assess by passive tone, that I have given example when we extend elbow and resistance felt during that is how the passive tone is assessed. And third one is active tone, and in active tone the when we do some passive movement, how it is being regained, or the posture is being regained, is that active tone. In passive tone, basically there are two basic signs or basic features which are scored in Ballard scoring. One is popliteal angle, another one is scarf sign. And in active tone, here also there is two basic signs. One is traction response and another one is arm recoil. We will discuss all these five one by one. First of all, posture. Posture, as the term approaches, flexors of the fetus increases its tone, and neonate adopts a posture of full flexion. As we can see in this image, that in first there is a total extension of upper and lower limbs, then there is slight flexion at hip and knee, then in third image we have flexion at elbow, knee and this hip. In fourth image flexion have increased, and in fifth image it is full flexion. And in scoring we can see that there is 0, 1, 2, 3, 4. In these all five posture are being scored like 0, 1, 2, 3 and 4. How the posture is maintained by the newborn, that will give us a score, like in this image. In this particular image we can see that newborn have attained the posture of full flexion at all the joints, at elbow, at hip, at knee, even fist is maintained. Then it can be scored as 4. Then second method of assessment of muscle tone, that passive assessment. In that we have discussed popliteal angle and scarf sign. So first of all, popliteal angle. Here we assess passive flexor tone by testing resistance to the extension of the knee joint. How we assess this? When a newborn is in supine position, we can see this in next image. Here a newborn is in supine position, and the thigh is positioned over abdomen in so-called knee chest position, and then we start this extending the leg by putting finger behind ankle joint. Here it is shown that the examiner is pulling from the foot, but usually the right method is we push the leg to straight it from knee by pushing behind the ankle joint. We put index finger behind ankle joint, and we push this leg over chest, and we measure this angle, that angle created by this extension. If the muscle tone of these flexors of the knee joint is high, then they will offer the resistance to this maneuver, and the angle will be less and less. That's why scoring, you can see that score is given 5 when the angle of this popliteal angle is less than 90. Score is 4 when it is 90. When it is around 100, then score is 3, and when it is 120, it is 2. Likewise, if it is around 180, there is no resistance of the flexors of the knee towards extension of the knee, then the score is -1. So this is all about popliteal angle. Then another one is scarf sign. In scarf sign, we assess the tone of the flexors around shoulder, the flexor muscles which flex the shoulder joint. Its passive tone is assessed by scarf sign. Here how we do it: in the scarf sign, in a supine infant, by holding this newborn's wrist and hand with one hand, and flexed elbow is being pushed by thumb of the other hand towards towards another shoulder, the opposite shoulder. We try to push the elbow as well as pull the hand towards opposite shoulder, and the position of the elbow in comparison to the midline will give us score. Here we can see that the score is being given -1, 0, 1, 2, 3 and 4. If this elbow crosses midline or even mid-clavicular line, it approaches anterior line of the opposite side, then it is -1. If it is up to mid-clavicular line, then it of opposite side it is 0. Up to midline it is 1. Same side mid-clavicular line 2. Same side anterior line 3. If it is not even approaching anterior line, then it is 4. This is how we score scarf sign. It also indicates passive tone, that is resistance felt to a movement of shoulder. Then active tone we assess by two maneuvers. One is arm recoil, another one is traction response. In arm recoil we assess by this extending here by in a supine infant, we in the flexed forearm we extend it by pulling the hand and wrist and then release, and we assess the recoil. Is the arm is kept in extension after leaving the arm after extending it, or is it recoiling towards its normal position, that is flexion. And here we can see that there is score of 0 when there is no recoil, and if it is slight recoil, the angle is 140 to 180, then it is 1, then 2, then 3 and 4 when the angle of elbow is less than 90, that is full recoil of the arm have occurred, then the score is 4. Then another maneuver for assessing active tone is traction response. In both these examples, we are not assessing the resistance felt to the passive movement. We are doing some passive movements, and then we are assessing is there any contraction, active contraction of the muscles to this passive movement, and this is assessed in arm recoil as well as in traction response. That is why it is active assessment of the muscle tone. And in traction response, we hold the newborn supine newborn is hold from wrist and hand, and we pull it towards ourselves and see if there is head, leg or not, and the response of the neck flexors. In this picture we can see that the infant try to maintain the posture of head with its body, and how strongly the neck muscles contract will give us the idea about the active tone of the neck flexors. However, this particular traction response is not scored in Billard score. So these all were about muscle tone. Then next second part was the four part neuromuscular examination. First was muscle tone, second was joint mobility. And in joint mobility, as we approach term, the joint mobility will increase due to the influence of various hormones released by mother, like relaxin, which also increase the mobility or stretching power of the mother's pelvic joints, so that there will be a easy labor, and also they will influence the joint of the fetus, so that the joints are not stiff and they are easily movable during labor. That's why joint mobility increases towards term, and it is assessed by square window test. What is the square window test? In square window test, we try to in a supine infant, we try to flex the hand towards the volar surface of forearm. We try to touch the palm to the volar surface of the forearm by flexing wrist, and we measure the angle. Here we can see that maximum score is given when palm is touched to the bulla surface of forearm. That is the angle, this angle between palm and bulla surface of forearm is being measured, and if it comes out to be 0, it is scored as 4. If it comes out 30 degree, it is 3 score. Likewise, you can say from the table. Then after joint mobility, third category or third feature in neuromuscular is automatic reflexes. These are also not scored in by large score, but they are very important in assessing gestational maturity. Automatic reflexes itself is a large topic, and we can take a separate class for this, but today we will discuss their appearance, basically their appearance and how to do them. The first is Moro reflex. In Moro reflex, in coming slides we will discuss how we will do and what we will see. In Moro reflex usually appears by the age of 28 to 30 weeks of gestation, and but it is not complete. The initial response, that abduction and extension, is there by the age of 30 weeks of gestation, but the complete the following adduction and flexion of upper limb will not be there by the age of 36-37 weeks. It will be complete by the 38 weeks. How much Moro reflex is present or which part is absent, it can give an idea about gestational age. But all these reflexes are only important when there is no CNS injury or malformation. As CNS matures with the increasing gestational age, when term approaches, CNS maturity increases. That's why these reflexes will mature at the time of birth or at the time of this term, and in preterms they will be immature, and by grading these immature reflexes we can assess gestational age. The second one is glabellar tap. In glabellar tap we usually tap the glabella and there is blink response, and this response starts or appears by the age of 29 weeks of gestation. Third one is grasp response. Grasp response, we put some finger in the palm of the newborn, and this newborn grasp our finger, and this particular reflex appears by the age of 30 weeks, but strong grasp, which we will discuss in coming slides, only will be after 36 weeks. Traction response, we have discussed traction response in previous slides, that neck flexors will contract in response to traction, and it will only appear by the age of 33 weeks. Rooting and sucking, a coordinated rooting and sucking reflex will only be positive by 34 weeks. Pupillary response to light appears after 30 weeks. When we put some light on the pupil, then pupil will contract to the light, that is pupillary response to the light, and it usually appear by the age of 30 weeks, and baby starts turning head towards light by the age of 36 weeks. This is Moro reflex. In Moro reflex, how we do this reflex? Usually we do sudden this extension of the flexed head of the newborn. We flex the head of the newborn and suddenly we release it by the 30 degree, and on releasing or sudden extension of the neck of the newborn, there will be this response, and in this response a positive response shows there is full abduction, that is the limbs are abducted, that is they are thrown away from the body. There is abduction of the limbs, upper limbs, extension of the upper limbs, and opening of the hands. We can see in both images there is opening of the hands as well, and this is first response which will appear by the age of 28 to 30 weeks. And in second part, this particular response will be, this is very rapid response. There is rapid abduction and extension as well as opening of the hand with there may be cry of the newborn. In second image we can see that the newborn is crying. Then this particular response will be followed by slow adduction and flexion of the limb towards body as it was before this response is elicited. There are two parts of the Moro. One is sudden rapid abduction and extension of the limbs with opening of the hand, and then there is slow adduction and this flexion of the upper limb towards body. And this particular second part, that is adduction and flexion, is not mature enough up to the 38 weeks. So this is all about Moro, and other things we will discuss in separate class. Then this is grasp response. We have put the finger in palm, and on touching this finger on the palm, baby respond by holding these fingers, by grasping these fingers, and this will appear by the age of this 30 weeks. But a strong grasp on which a newborn term baby can be hold on these grasp on two fingers, we can totally this newborn can bear its total weight on this particular two grasp. But this mature grasp only appears after 36 weeks of gestation. This is rooting. In rooting and sucking, when angle of mouth or cheeks of the baby is stimulated with nipple, or like in this image by finger or even pen or anything, we touch something over angle of mouth or cheek, baby tries to move towards the touching object, and then it will put this object into the mouth and starts sucking. And this coordinated rooting, sucking and swallowing only appear after 34 weeks. That's why a newborn of less than 34 weeks will not be able to properly breastfeed. They are either fed on expressed milk by Katuri spoon, or they may be require this NG feeding, or may require parental feeding. Then last and fourth category of neurological examination is fundal examination. And in fundal examination, usually we categorize or we grade the changes in anterior vascular capsule, vessel changes. Before 28 weeks, the this anterior capsule is totally vascularized, and after 34 weeks of gestation it is completely avascular. And between 28 to 34 weeks there is gradual changes from vascularization to avascularization of the capsule, and these changes are being graded for gestational age assessment. However, fundal examination is a very tough procedure because newborns are always photophobic, and examining fundus is a tough job. That's why these are not included in that blood scoring. So this was all about gestational age assessment. It is my third lecture, and I have not received your feedbacks, and a single query was there for last lecture. It indicates that you people are not giving proper time to the studies. अभी हालत ख़राब है, पता नहीं कितने दिन कॉलेज चलेगा नहीं चलेगा, एंड पेपर जो है टाइम से हो सकते हैं, तो आपको टाइम बहुत कम मिलेगा और सिलेबस बालों का बहुत ज़्यादा है, तो वो सेल्फ स्टडी करो और जो पढ़ाया जाता है उसको जो है थॉरली इसमें तो पढ़ो ही पढ़ो, बाकी बुक्स में भी जाके पढ़ो, और कोई भी क्वेरीज होती हैं या कोई आपको लगता है कि हाउ टू इम्प्रूव दिस ऑनलाइन क्लासेस, you can give feedback on my this WhatsApp number. and ज़्यादा से ज़्यादा फीडबैक और क्वेरीज होनी चाहिए ताकि अगले लेक्चर बनाने में हमको भी जो है अच्छा लगे कि नहीं बच्चे पढ़ रहे हैं. ओके, थैंक यू.